All right, I think we should get started. So welcome to the final formal talk
for the
the
year.
liver division this year. We'll be starting in 2019. Feels kind of weird to say that. So JP is going to give us a talk on vascular and biliary complications after liver transplantation. So the second part of the series of essential topics. So JP, thanks.
All right. Thank you all for having me talk about this topic. And like when we talk about transplantation, we always complications associated with transplantation. We almost always talk about rejection, but we forget about this particular aspect of post-transplant care of patients, which can significantly affect patients' quality of life, could cause significant morbidity, mortality, healthcare costs, and all of that. So I think this is actually an important topic that needs a lot of attention, and I'll try in the next hour to go over these vascular and biliary complications that may occur after transplantation. I designed it to be a fairly general overview of this topic, including where I can, including whatever evidence is out there on management. So I don't have any disclosures. I have a couple of broad objectives for this talk. The first is to kind of describe the hepatic, vascular, as well as biliary anatomy in relation to liver transplantation, because that helps us understand these complications a lot better. And then after that, we'll go into the different kinds, the workup, the management of these complications that can happen after transplantation. So I think it's important to start with what exactly happens during a transplant. I think if we're discussing biliary and vascular complications, we have to know what connections are happening when a donor organ goes into a recipient. And so the first, you have the anastomosis, the connection between the vena cava. Second, we have the biliary anastomosis. Then we have the arterial anastomosis, the hepatic artery, and then finally you have the portal anastomosis. It's important to know these because when we think or talk about these complications, we have to go back to these connections. So I divided this into two parts. The first part will be talking about vascular complications. The second part will be talking about the biliary complications. So we start with a little discussion about the hepatic vasculature. So the liver has a dual blood supply. Here in this diagram, we show the blood supply coming from the hepatic artery. It supplies 25 to 30% of the blood supply of the liver. It carries oxygen-rich blood, and importantly, it supplies both parenchyma and the biliary tree. In fact, the biliary tree exclusively is being perfused by the hepatic artery and its branches. The second supply is the portal vein. The portal vein actually supplies more or a greater proportion of the blood supply of the liver, up to 75%. This carries nutrient-rich blood from the gut, and it supplies the liver parenchyma. Now, the next thing to think about is the hepatic outflow. So the drainage of the blood that perfuses the liver empties through the hepatic veins and up to the inferior vena cava. Now, I wanted to talk, so I found that important because when I talk about the vascular complications, I thought it would be good to divide it into complications involving inflow, which is the hepatic artery and the portal vein, and those involving outflow, which is the hepatic vein and the vena cava. So we'll start with the hepatic artery. So probably the vascular complication that we should all be aware of is hepatic artery thrombosis. It's the most common vascular complication after liver transplantation. Essentially, it's a clot that forms within the hepatic artery. We make a distinction between HAT, hepatic artery thrombosis, or HAT, that occurs within 30 days, which is called early, and those that occur after that, which is called late. And the reason for that is because the clinical course and the presentation kind of varies between the two. HAT occurs in about 4% of adult liver transplants, and the incidence of HAT has actually decreased through the years, from about 25% in the 80s and currently now 5% or less because of improvements in operative care as well as surgical technique. Early HAT is more common than late HAT. and the incidence of HAT in deceased donor and living donor transplants are about the same. Now, there are several risk factors for HAT, and these could be divided into those that are, in the surgical realm and the not surgical realm. So in the technical side of things, in the surgical side of things, these are some of the risk factors that could predispose to HAT: a small artery, a small celiac trunk, so small vessels, some technical imperfections. If the procedure is difficult and it requires complex reconstruction, or if the anatomy is aberrant or anomalous, if there's high microvascular resistance, as if there is rejection, and also if there was aggressive clamping of the hepatic artery. Now, on the right side, these are the non-surgical risk factors for HAT, and a lot of them, a number of them have got to do with the perfusion of the donor liver. And so you have a long cold ischemia time, patients who have ABO incompatibility, those who have rejection, obviously patients who have hypercoagulable states, patients who smoke. I mean, they're just at risk of forming clots in all sorts of vessels, retransplants, people who have had HAT in the past. Interestingly, patients who have received TACE are at increased risk for HAT, and they say it's because the TACE kind of damages the endothelium, which predisposes to HAT. CMV infection also predisposes to this. Through a similar mechanism, it kind of induces damage in the endothelium as well, which predisposes to platelet aggregation.
Was equally true for early and late? I would think that surgical will probably be a bigger problem early.
Correct. So surgical problems, surgical risk factors, these are for early HAT. These are mostly for later HAT. Correct. The most common presentation of HAT is high transaminases. In some cases, patients become symptomatic. They could develop biliary complications, which we will talk about earlier. I mentioned earlier, the biliary tree is exclusively supplied by the artery. So any problems with the hepatic artery can cause biliary problems. Fever and sepsis and graft dysfunction can cause, can be presenting symptoms or presenting signs of HAT as well. Now, the presentation varies according to onset. Early HAT, as Dr. Friedman pointed out, these are usually from technical or surgical factors. Early HAT tends to be acute and severe. These are patients who may have primary non-function or fulminant liver failure. And early HAT without prompt treatment can lead to graft loss and mortality in about 50%. Late HAT, on the other hand, is usually due to more of like patient or recipient-related factors. So these are ischemic factors or immune-mediated processes. Typically, the late HAT has a milder, less severe course, and this is where a lot of the biliary complications start coming in. Now, when we think of the clinical presentation of HAT, a lot of people think of three classic syndromes of patients who have HAT. The first one is a patient who will present with fulminant hepatic necrosis. You cut off the blood, you cut off the hepatic arterial supply, and then the hepatic parenchyma just necrosis. And because as a result of that necrosis, there could be secondary hepatic infection. The liver could become gangrenous, could form into like a big abscess, and without retransplant, 75% of patients will die. The second is ischemic necrosis of bile ducts. You cut off the blood supply to the bile ducts, and the bile mucosa starts breaking down. You can start having bile leaks, leaking into the peritoneum, peritonitis. You'll have sepsis, and without retransplant, 50% will die. And finally, similar concept, if you break or if you disrupt the bile mucosa because of ischemia, then you have bacterial translocation, you have relapsing bacteremia or recurrent cholangitis, and 60% of patients will also die without retransplant. Late HAT, as we talked about, usually a milder, more benign course. Most patients would be asymptomatic, except for some elevated liver chemistries. And the patients who are symptomatic will present with biliary complications, which we'll go into much detail later. Now, the diagnostic workup of HAT, early diagnosis is critical for patient and graft survival. For screening, Doppler ultrasound would probably be the best test to do. It's quick, it's readily available, it's very sensitive. Some centers would do routine Doppler ultrasound at 48 hours and 7 days after transplant, so that they could catch something early and do something about it. And as you know, with any kind of ultrasound, it's affected by intestinal gas, respiration, and sluggish blood flow. And then if there's suspicion for HAT in the Doppler ultrasound, you need to confirm that with angiography. And you could either do imaging-based, CT or MRI-based angiography, or conventional angiography. A lot of people would do or would prefer CT and MR because, you know, it's less invasive, there's no risk of vascular injury, and it's similarly or equally accurate compared to conventional angiography. Now, HAT treatment, I think of, you know, the way we treat HAT, I kind of lump them into 3 general categories. The first one is retransplantation. This offers the best option for survival, but as we know, organs are scarce, and, you know, transplant has high perioperative morbidity and mortality. So which leads us to the second option, which is revascularization. We try to reestablish blood flow through the hepatic artery, and there are several ways that could be done. That could be done, you know, through endovascular techniques like intra-arterial thrombolysis, angioplasty or stenting, or even surgical revision of the anastomosis to establish blood flow. And in some cases where patients, you know, have HAT but are otherwise asymptomatic, it's completely reasonable to observe. And you do very close monitoring, watchful waiting, you know, until they become symptomatic. Now, in managing HAT, I mean, there are, you know, as we talked about earlier, there are certain classic scenarios where HAT presents, and it's good to know what these scenarios are because the way you manage it is actually kind of different based on these scenarios. So the first one is patients who get early HAT and then develop pulmonary liver failure necrosis. These patients are best served with early retransplant. In fact, if you have HAT that occurs within one week of transplant, you could list them as 1A. Meanwhile, you got to make sure they're on broad-spectrum antibiotics. You got to resuscitate them, and occasionally, if there are no immediate offers for organs, it's an option to remove the liver. Just make them anhepatic, because I mean, if that liver is necrotic and, you know, infected and gangrenous, it's just a big problem. Just take it out and then put the patient in a bypass. If possible, avoid, you know, extended criteria organs. Try to give the patient like a healthy organ to offer the best outcomes. Now, in patients with early HAT who are only mildly asymptomatic, then early revascularization becomes our priority. And so the options are surgical or non-surgical. Non-surgical revascularization are best for mildly symptomatic patients who have acute to subacute lesions. And the next 3 bullets are the options. You have intra-arterial thrombolysis, you could have angioplasty, or you could have stenting. And these are things that the interventional radiologists do. The risks with non-surgical revascularization include bleeding, dissection, or even artery rupture. If, for example, these are unsuccessful, the surgeons could try to surgically or operatively revascularize. And if that's not an option either, then you have to consider retransplantation. How about patients with late HAT? In patients with late HAT with biliary complications, retransplant is preferred over revascularization because when you revascularize, you only address the vascular issue, but not the biliary issue. And sometimes while you wait for retransplant, you might have to drain abscesses, or you might have to even do a partial hepatectomy, you know, depending on the complications that develop as a result of this. And finally, late HAT patients without symptoms, expectant management is fine. Why are they asymptomatic? Because if HAT develops fairly late, or, you know, fairly chronically or fairly slow, that gives the vessels enough time to form collaterals to provide adequate perfusion. So that's HAT. The next thing we talk about is hepatic artery stenosis. Yeah.
Quick question. In your reading,
Yeah.
did you see any models of prediction that helps you understand which way you should treat these patients? Because, you know, it's a very fresh 30-day, you know, patients,
right,
and potentially subject them to lifelong misery with ischemic angiopathy. You know, and I'm not sure if you can touch on sort of minimum requirements for status 1, right?
Oh, I didn't go into that detail. I could send an email to everyone about for more detail. And also, I also didn't go into some of these predictive models for the presentation today.
Yeah, I'm not aware of it. So.
Okay. Can I ask for, so if someone's getting listed as status 1A for early HAT, within peri-transplant period, what is the clearance process? Because if we're just cleared for a transplant a couple of weeks ago, do you have to go through the whole process again, or is it just like you see HAT, you can just clear right away as hey?
Yeah, I mean, one of the minimum requirements we talked about is it's actually a transaminase test, right? So it's AST greater than, I think it's 3,000. 3,000, right? It's one of the requirements. There's some other ones as well, INR, things like that. So basically, it's like an ALF picture. But one thing that is unique is the hepatocellular injury. There's a requirement that's unusual for hepatology.
You can also, if they present with after 70 days, so within like 2 weeks, you can list them with a null of 40, so they don't get status 1, but they still get priority. So just something else to keep in mind.
Gotcha.
I wonder also, do you try to first open it up before you go in and try to do thrombolysis to try to not have to relist? The usual scenario.
From what I was able to read, I mean that's a good point actually. But from what I was able to read, a lot of people would just, if they meet the criteria, would just list for retransplant as 1A. Right.
They can't even go for like
Yeah. And the other concern is the bile ducts have already taken place. When you get them through the next few weeks, they survive, then you're left with the strictures and the return processes, and you've lost your window to get them prioritized for retransplant.
Yeah, I would say in general, I mean, I haven't seen, luckily, very many of these cases, but I think the surgical approach, at least here, is more to just redoing transplant because we've seen so many disasters. So then it basically become terrible, secondary sclerosing cholangitis kind of patients.
Right. Hepatic artery stenosis is a little different. I mean, whereas HAT is a clot that occludes the hepatic artery, with hepatic artery stenosis, it's a narrowing of the artery itself. And the idea is the same. It leads to graft ischemia, biliary problems. Hepatic artery stenosis is a triad of, you have a more than 50% narrowing in angiogram, a resistive index more than 0.5, which means it's narrow and blood flow through it is slow. And because it's a narrowed lumen, the systolic velocity through it is high. And if hepatic artery stenosis is untreated, sometimes it progresses to HAT. And the reason for that, if you have sluggish flow through that, then you have blood stasis and you could form HAT. And the incidence of HAT after 6 months of untreated HAS is about 65%. Risk factors are actually quite similar. You have operative factors, you have clamp injury, you have faulty sutures, you have donor-recipient factors. And among these factors, what's actually important is a discrepant vessel caliber. So if the recipient and donor vessels are of different sizes, then the surgeons would have to do an oblique anastomosis, which can create issues with the patency of the lumen. And then microvascular injury can do something similar. The clinical presentation it typically presents later, so more than 30 days is more common presentation. The stenotic area is typically in the donor side of the anastomosis. It's because it's usually in the donor side of the anastomosis. I believe the vascularity in the recipient side of the big vessel is better. The most common presentation is an asymptomatic elevation of liver chemistries. These patients are less likely than HAT to have graft failure or biliary complications. And the reason for that is because, this is stenosis, so the onset is slow and there's enough time for collaterals to develop. There's some authors are saying that the presence of HAS might be an indicator of chronic rejection, but I wonder if in those studies, because the numbers are up, they biopsy and they just find chronic rejection because of the biopsies, because of the frequent biopsies. The diagnostic workup is similar as HAT. You start with Dopplers and then you confirm with angiography. And this is an example of, hepatic artery stenosis. And in this area, you see a very abrupt narrowing of the artery over there. The preferred treatment approach is for vascularization. You try endovascular first. If that doesn't work, surgical. If that doesn't work, you have to retransplant. Endovascular intervention is preferred because it is as effective as surgery, but obviously has lower mortality and morbidity. The best lesions or the best indications for endovascular interventions are stenoses that are short, as well as those that are not accessible to surgery. Or when you say hostile abdomen, these are patients who've had several surgeries, a lot of fibrosis that, opening them up again might not be the best idea. And then we talk, about miscellaneous conditions, a couple of them. Hepatic artery pseudoaneurysm. If you damage the wall of the hepatic artery, blood kind of flows out, gets walled off, and you have this kind of false aneurysm in the tissue surrounding the artery. And this is treated with either embolization, stenting, you could, or surgical revision. And then a catastrophic event is when the hepatic artery ruptures. And this is a very big bleed, which obviously needs urgent or emergent XLAP. They have to ligate the artery, revise the anastomosis as well. All right, next, portal vein, very quickly. Point thrombosis, it's a lot less common than HAT. It's typically an early complication. Median onset is 5 days. Two kinds of presentations. The first is early PVT, usually presents with graft failure or elevated liver chemistries. And if it develops later, then you develop portal hypertension because of it. Risk factors, actually very similar to HAT, technical problems, but pre-transplant PVT is a risk factor. A small vessel is a risk factor. Patients with large collaterals or patients who underwent splenectomy are at risk of this as well. The workup is the same, Doppler and CT. And treatment, endovascular interventions, surgical revision. It's again the same thing, but there's an option of systemic anticoagulation as well. Treatment, so PVT that develops within 48 hours needs surgical treatment and systemic anticoagulation, maybe even retransplant. PVT that develops, after that may respond with endovascular intervention, very high success rate. The interventional radiologists can do angioplasty either with a transhepatic or a transplantic approach. And they could also do catheter-directed thrombolysis via TIPS. And then PVT that develops late, typically, if they develop a cavernoma and they're asymptomatic, you just observe them. If they develop systemic portal hypertension, you could consider, if there's no cavernoma, you could consider endovascular interventions or thrombolysis. And then lastly, hepatic vein cable obstructions. It's good to know how surgeons reconstruct the cava. In the classic anastomosis, when they remove the recipient liver, they remove the vena cava as well. And so when they put in the new donor liver, they anastomose the donor vena cava to the recipient vena cava. In the piggyback technique, the whole recipient IVC is intact, and what they do is they attach the donor IVC into the hepatic vein confluence over here. And then, you could develop obstruction through either kinking, stenosis, or thrombosis, very rare. And it presents with because this is outflow obstruction with like a Budd-Chiari type picture. You have edema, hepatomegaly, ascites, occasionally liver failure. Workup, same. Treatment, again, endovascular intervention is key here, low mortality rates and good efficacy. And that could be done via angioplasty and stenting. And of course, if the allograft fails, you need to retransplant.
So question, when is it appropriate to prophylactically anticoagulate somebody?
So for after transplant, so that, that's very controversial. I've looked at certain, I've looked at different authors saying different things. Some say that there's really no benefit, but some say, well, there's no no significant harm. It doesn't increase the risk of bleeding. So
Yeah, I mean, if you have a patient who's had a DVT or mesenteric thrombosis, or they're known to be hypercoagulable or vector-5 line or something else, it's possible to.
right. So some are recommending that, but they do. But what they recommend is aspirin. I haven't encountered people who actually recommend therapeutic anticoagulation. So I have to look more and see if there are centers who are doing.
A long discussion with the hematologist going into transplant and any recommendations of surgeons what to do immediately afterwards. Depends on what their coagulation problem is. If it's related to liver synthetic function, then that should improve after transplant.
It was everyone who's put on aspirin as part of the protocol.
Gotcha. They say forever. They say on it forever.
Yeah.
I mean, in a little bit.
Yeah, them elsewhere. The only other thing, just because this was just on
Yeah.
boards,
Yeah.
in terms of differences in technique for cable anastomosis. So there's a slightly higher risk also of post-transplant ascites in the feedback, just because of the way the anastomosis components there. So those are questions on boards.
Gotcha.
Did you get the question right?
I think so, I passed. So
All right. So the second part, talk about some of the biliary complications. So when we talk about biliary complications, we also need to know how the surgeons reconstruct the bile duct. So the first one is, this is the popular technique. It's a choledochostomy. So they anastomose the recipient and donor common bile duct. They like this because it's technically easier. The recipient common bile duct is well vascularized. It preserves the sphincter of Oddi, which prevents enteric reflux and maybe reduces the risk of cholangitis. And if some, biliary complication developed, then you could get to it through an ERCP. The next anastomosis is a Roux-en-Y choledochojejunostomy. So they connect the bile duct. So they connect a Roux limb first, and then they connect the donor bile duct into the recipient jejunum. And this kind of reconstruction is indicated for patients with discrepant common bile duct size, patients with diseased ducts, so those with PSC, biliary atresia, or cholangiocarcinoma, those who've had prior biliary surgery, reduced size transplants, split grafts, or living donor. If, for example, the patient develops a biliary complication that needs a revision, then the revision of the bile duct will be this. Those who get retransplanted and those with suboptimal blood supply. There are several disadvantages, including an increased OR time, a higher risk of anastomotic stricture or leaks, because you effectively there's no sphincter here. There is hypothetically a higher risk of cholangitis because of enteric reflux. And also because bile will have to go all the way down here before it mixes with, stuff in the anastomosis. There's delayed mixing of bile, and it can also alter cyclosporin absorption in patients who are on cyclosporin. And if, heaven forbid, a biliary complication develops, it's almost, you have to do a balloon to get there. It's very difficult to get to the anastomosis.
You go back to the previous one?
This one?
The previous picture? On the picture there, do you guys know what that tube coming out of?
So it's a T-tube?
Yeah.
We'll talk about it.
Good.
So yeah, that's a T2. We'll talk about that in a bit. All right. So the bile duct, important to talk about the vascular supply of the bile ducts. The recipient common bile duct the supraduodenal common bile duct is supplied by the pancreaticoduodenal artery, whereas the donor common bile duct is supplied by the hepatic artery in its branches. This is more susceptible to ischemic injury, and that's why sometimes patients who have ischemic biliary strictures, it's in the donor side where they develop that. Now, there's this question about T-tubes, the T-tube or not the T-tube. So the T-tube, so here's the T-tube over here. What it does is, they place it within the duct, And the idea is that the tube kind of stents the duct so that it doesn't stricture. So they say that it prevents anastomotic stricture. Those who are in favor of it says that it prevents anastomotic strictures. And because you have access to the biliary tree, you could actually check on bowel quality as well as biliary anatomy. You could do a cholangiogram easily. On the other hand, those who are not in favor of T-tube cite an increased risk of bile leak. So the T-tube doesn't stay there forever. At some point, it needs to be pulled. And when you pull it, then there's the possibility of a bile leak. And so that's why some people don't like it. Now, I combined results from a few studies over here, and those with T-tubes have higher risk of biliary complications, a higher percentage of positive bowel cultures, higher percentage of bile leaks. They didn't give the p-values, but I'm assuming it's significant. And the maybe slightly numerically lower percentage of strictures, but it's not statistically significant. Biliary complications happen in about 5 to 25%, majority of it within the first 6 months after transplant. The most common complications are strictures and leaks. But so in the post-MELD era, in the contemporary period, we've been seeing more strictures and fewer leaks. And they're saying the reason for this is because we're using more cardiac death donors, and we're using less T-tubes. And strictures are more common in living donor than in deceased donor transplants. Now, why do these develop? The biggest thing is ischemic injury. So you could have macrovascular problems if the hepatic artery is occluded. You could also have microvascular problems. So if there's a long ischemic time, cardiac death donors, preservation injury, if the donor was on pressors, if the donor was older. Immune-mediated problems can also cause the biliary complications. So you have ABO incompatibility, rejection, PSC in particular. You can get recurrent PSC. Reperfusion injury can cause the same issues, and the bile salts themselves can be cytotoxic and can lead to inflammation and eventually fibrosis. Now, we'll talk about. We'll go through general categories of these biliary complications. Let's start with biliary stricture. So these are some of the risk factors. As you see, we talked about we talked about majority of them being related to ischemia or immune-mediated processes. There are two main types of biliary strictures. There are strictures that develop in the anastomosis, and this is the majority. And then there are also strictures that develop away from the anastomosis. Now, these are strictures that develop because of ischemia. It's kind of good to make that distinction because their characteristics are different. So anastomotic strictures are typically short, isolated, and localized in the anastomosis. Non-anastomotic strictures tend to be long. They're multiple. They could be in the intrahepatics or extrahepatics, and because of bile stasis, they're usually associated with casts and stones. Their incidence is about the same. Anastomotic strictures are more common in the Roux-en-Y anastomosis. Strictures are usually late complications, whereas anastomotic strictures are typically thought of as later complications, whereas non-anastomotic strictures are usually thought of as early complications. Those non-anastomotic strictures that occur within the first year, probably from ischemia. Those that occur after 1 year, probably immunologic. So for example, the recurrent PSCs or the rejections. And then causes of anastomotic strictures, you have scarring, technical failure, local ischemia around the anastomosis. For the non-anastomotic strictures, it's multifactorial. You have ischemia from macro and microvascular problems like these ones. We talked about them already, as well as immune-mediated processes, which we've already talked about as well. I do want to point out that PSC can recur in the graft, and it has up to 20% recurrence.
I was going to ask you, what about patients who have pre-existing PSC strictures, extrahepatic strictures? Obviously, that's not suitable for surgery. So what's done then to avoid immediate strictures due to underlying PSC?
So I think for patients with diseased ducts, what they do is instead of doing a bile duct to bile duct anastomosis, they do a call it docogenostomy. So they do a hepatico-J. So to try and minimize, remove, the extra hepatic, just cut it off.
Yeah, my understanding that's routine, even if they don't have clear cut, CB strictures.
All right.
Mhm.
So
Mhm.
whether they have intra or extrahepatic PSC strictures?
That's my experience.
To the risk of cholangio.
Yeah.
Hmm.
Right. Okay. That makes
They
sense.
can also connect the bile duct to the duodenum too, so they don't necessarily.
Have to do a root.
Some programs actually just, they call it duodenoscopy.
Mm-hmm.
But just
Anastomotic strictures usually have a good prognosis, rarely leads to graft loss, whereas non-anastomotic strictures are more difficult to treat, and they're associated with more complications that could potentially lead to graft loss or even patient death. So this is the clinical presentation of biliary strictures. Patients will present with cholestatic liver tests. They'll come in jaundiced, itchy. If they have cholangitic symptoms, they can have fever, they could have pain. We mentioned earlier that cyclosporin depends on bile for absorption. So if you have unexplained fluctuations of cyclosporin levels in patients on cyclosporin still, you got to think about that. But sometimes patients are asymptomatic. They don't feel anything, and that could be because the liver has been denervated or that some of these infectious symptoms may be masked by steroids or immunosuppression. Now, how do you work up the biliary stricture? So someone comes in with abnormal liver chemistries, maybe compatible symptoms. Maybe in some people they will automatically proceed with a liver biopsy. The problem is it's invasive, and if you have a biliary obstruction, you'll have portal inflammation, and so that could be misread as rejection. So it's probably not ideal as first-line testing, and so we should probably start with Doppler ultrasound because it allows us to look at the vessels, look if there's hepatic artery problems that could cause biliary issues. At the same time, it also gives us a good, like a cursory view of the biliary tree. If there's something abnormal, that's good, it's specific, but it's not really sensitive. A normal ultrasound will not rule out strictures. If you're still highly suspecting a stricture, then you have to proceed with further testing. In patients with Roux-en-Y anastomoses, or those who are at high risk for ERCP, MRCP is obviously the best bet. Very sensitive and specific, minimal risk. The problem with MRCP is that it's not therapeutic. You only see. And in patients with clips, you could get artifacts that would also interfere with image quality. In patients with a T-tube, then you could do a T-tube cholangiogram and just see how things look. Cholangiography in T-tube is actually routinely done before they clamp the T-tube and before they remove it to look at the anatomy, usually between 6 weeks and 3 months post-transplant. On the other hand, in patients with an intact intact anatomy, like native anatomy, right? Or sometimes if your pretest probability is already high, then maybe you could skip the MRCP and proceed with an ERCP. And the advantage of the ERCP, of course, is that it's therapeutic. But of course, it carries the increased risk of post-ERCP pancreatitis. And I read somewhere that the risk of post-ERCP pancreatitis might actually be higher in transplant recipients than non-transplant recipients. So this is, So this is an anastomotic stricture. So you can see it's very, localized, very short. Here it looks long, but it's very smoothly tapering and it kind of disappears there. This is a longer stricture, so this is a non-anastomotic stricture, and here you see it's just kind of like a long segment that's kind of out. All right, so how do you treat them? So anastomotic strictures for patients who are deceased donors, the treatment of choice is ERCP with balloon dilation and stenting. Combination is better. Balloon alone is said to be inferior. The preferred method of stenting is multiple plastic stenting. So what this means is, you put a stent in, and then you keep on adding stents to expand the diameter of your stricture. And sometimes patients would need up to 4 sessions over 12 to 24 months to resolve the stricture. Fully covered metal stents are said to be inferior. The success rates are lower, they have more failure, more adverse events, particularly pancreatitis, more recurrence. Uncovered metal stents are just not recommended. The problem with these is they're not removable. Like when you put it, it's there forever. In patients with Roux-en-Y, PTC, and an internal-external drain, and if everything fails, surgical revision. How about non-anastomotic strictures? So it kind of depends on its relationship with HAT. If this is associated with early HAT, then you want to treat it as you treat HAT. If it's associated with late HAT, then you want to do endoscopic intervention of the stricture. The issue with these non-anastomotic strictures is that they're a lot more difficult to treat than anastomotic strictures. Their success rates are lower. They need more sessions and a longer treatment duration. And sometimes, because they're not limited to the anastomosis, some of the lesions are intrahepatic and not accessible by the ERCP and the stent. Sorry. Now, for living donors, they're more difficult because there are more ductal anastomoses. The success rate evidently is, expectedly is lower, and the recurrence rate is higher. It's also more difficult to cannulate because the ducts are smaller, so the strictures are tighter. And then there's this crane neck deformity that's described by the Japanese. And so this is the recipient duct over here. You see here the donor duct. Before this should be a straight line, but as the lobe hypertrophies, it kind of pushes things down and you have this crane. And when you have this, you can't cannulate that. And the worst success rates, non-anastomotic strictures in living donors, endoscopic therapy is only less than 30% effective, unfortunately. So this is an example of a biliary stricture. And when you say multiple stenting, they can literally like stuff it with stents. And after that, what's better? So, retransplant is an option in biliary strictures, particularly in patients who develop biliary cirrhosis, those with persistent sepsis, those who are not eligible for revision, and those with recurrent PSC. How do you prevent them? Well, the data in randomized controlled trials suggests that T-tubes actually do not prevent anastomotic strictures. And for patients with living donors, just improving the surgical technique. We don't really need to, this is really from the surgeon side. There's data that to prevent non-anastomotic strictures, you could pressure perfuse the preservation solution through the hepatic artery to ensure that it perfuses the entire capillary system, and it can decrease stenosis rates. How about bile leaks? Bile leaks, similar incidence rates. The common sites of leakage would be the anastomosis, the cystic duct remnant, T-tube, very important. And in patients with split grafts, the surface the area where they cut the surface. So there are two kinds of bile leaks. You have anastomotic or T-tube related, and you have non-anastomotic or non-T-tube related, which is related to duct ischemia and breakdown of the biliary tree. There are early and late bile leaks as well. Early leaks are much more common than late leaks. And this is the cause of early leaks would be related to the T-tube, surgical problems, local ischemia of the bile duct, or leakage from the cut liver surface. Late bile leaks usually from stent migration or in T-tubes that are removed late. Clinical presentation, really the same as very, very similar to biliary strictures. How do you work them up? Similar, you start with ultrasound. The caveat with ultrasound is that it's good for the ducts, but not really very good for fluid collections. CT is better than MRI in looking at fluid collections, and really you need cholangiography to diagnose the bile leak, and here you see the leak over here. How do you treat them? Depends on the anastomosis. In patients, the goal of treatment of bile leaks is to reduce the intraductal pressure so that you divert the bile flow away from the site of the leak. And it depends on what kind of anastomosis the patient has. In those with choledochal ERCP would be okay. In those with Roux-en-Y's, you can't do ERCP, so you have to do percutaneous. And in those with T-tube related leaks, you might want to do a T-tube cholangiogram to localize the leak. If you keep the T-tube open, bile will flow through the T-tube, not through the leak. And this in some authors, they report spontaneous closure in half of patients in 24 hours just by doing this. If, for example, the leaks are too large, they become infected, or there's associated HAT, then you really need to consider surgical revision. You want to debride infected or necrotic tissue. Generally, bile leaks have better prognoses compared to strictures. In the largest, actually this is the largest systematic review of bile leaks. There were no retransplantations, and the mortality is only 2%, and this was due to sepsis. And then lastly, these are just miscellaneous lesions. Sphincter of OD dysfunction, we all know, what this is. This is the same as in patients who are, not post-transplant. It's believed to be due to denervation of the sphincter of OD. And sometimes when you clamp the T-tube, if the sphincter of OD is not functional, then you get abnormal LFTs because the bile isn't draining. Diagnostic workup. It's really about when you unclamp the T-tube, you have normalized LFTs. Sometimes when you do an ERCP, there's delayed emptying of contrast. The HIDA is abnormal. Some would do sphincter of OD manometry, but pancreatitis risk of this is very high. And you treat with sphincterotomy and stenting. Sludge stone casts usually associated with strictures, and they can and also infection, so cholangitis. Interestingly, calcineurin inhibitors, particularly cyclosporin, is lithogenic. It reduces bile flow, and it also induces bile stasis. And you treat them as you would treat any casts, any stones. You remove endoscopically. If you can't do that, you try surgical extraction. If we're talking about smaller lesions and the patient can't get surgery, then we could try medical dissolution therapy with orso. Mucocele, so if the cystic duct remnant is not draining mucus properly, then it creates this big mass in the stump, and this can cause CBD obstruction as well. And surgeons would just need to surgically remove that. And lastly, some patients, post-transplant patients, actually any patient who get a liver biopsy, they can develop hemophilia through formation of arteriobiliary fistulas. They could have bilhemia, so the bile leaks into the vascular system through these fistulas. And if this develops, you want to control the bleeding through embolization, or through embolization primarily, and you want to relieve obstruction through by removing the thrombus. And that's it for today.
Thanks, JP. That's great. Questions?
Well, let me just say that was about as perfect a presentation, particularly the slides, as I've seen in a long time.
Thank you.
Great job.
Thank you. I think I would just point out one thing about the aspirin, which is always a question.
Yeah.
I mean, I don't know if there's great data for that, but I do think that one of the things that I've found that the aspirin is useful for is with the next talk that's going to come along that I think Eugene's going to talk about with metabolic complications, because I think that there's a lot of now data for aspirin as prophylaxis against cancer and PSC for cholangio, and then the metabolic benefits of that too. So, okay. Very well, JP.
Thank you.